Hello.
Yes, sir, we
Hello.
can start, sir.
Yeah. So I think it's slightly complicated. So I would probably ask either, Vinod, do you want to go have a go at this, or shall we wait? Ask for Nitya or Sanya.
Sir, I read these things during my exam, sir. So,
Yeah.
be-
Then
yes, sir.
educate us. This is not just about finding out whether you know it or not. I think it's also education. Okay. So what do you think should we do?
Yes, sir. Generally, we have to explain as much as possible to convince so that the patient will understand the things very, in a proper way. So, if still the patient says no, then the final decision is the patient, sir, which is we call it autonomy.
Okay, fine. Nikita and Praveen, do you want to address this? What do you think?
Yes, sir. I go with what sir has told, sir. First, we explain him what the condition is and what all the complications which are going to happen if we do not proceed with whatever the proposal we had put forward, sir.
Yeah.
So, if the patient agrees, we can go ahead. If the patient doesn't agree, we need to we need to write down whatever we had explained him. If possible, a video counseling recording. Then we need to take their signature for the future medical legal problem issues, sir.
Okay. I think you answered a few things. I think the most important thing is, first of all, see the Nitya and Sanya. This is the same question mark, Nitya?
Yes, sir.
Okay. Well, is that the second slide you put up is the same patient?
Yes, sir. Same for the question.
Okay.
These are the
Okay.
sub questions, sir.
Okay, right. Yeah. I don't know. You stop sharing, is it? I can't. I'm just seeing Dr. Lakshman's face there.
Yes, sir,
Yes,
were
sir.
saying-
He has
able to
stopped
see it.
sharing.
The Lakshman sir is there.
No, sir. That's me only
Okay,
from
right.
sir's account.
Okay. Share it again. Let us see what the questions are there.
Yes, Samir was sharing, sir. He had the PPT.
Samir, what happened, man?
Sir, I was there only.
No. Go back to the previous question.
Hello, sir, can you see it?
Yes, Samir.
Yes.
Next.
No, which was the question you were sharing?
Sir, this one, sir.
Yeah.
Yes, sir.
So this is the question, but those are the sub questions, sir. Like specific questions.
Yeah.
Next
Okay.
slide.
See, go to the next slide, man. Okay. So, right now, Tanya, you want to answer this question?
Yes, sir. Like everybody said, since we cannot go ahead with anything without the patient's consent, I will explain in detail regarding that this situation can be life-threatening for him also if we don't go ahead with the procedure, and explain him all the pros and cons of doing and not doing the procedure. And despite that, also, if the patient doesn't want to go ahead with it, then he will not force himself. And also, we have to document everything to be on the safer side, like Nikita said, for medical legal purposes.
Yeah. See, yeah, I think I'll just sum up. One is, is anyone like to elaborate on what are the pillars of ethics and what ethical principle is behind your move? Vinod? Hello?
Hello.
Vinod,
Yes, sir.
Hello, sir.
What ethical principle is behind your move of explaining everything?
Sir, beneficence, sir.
Beneficiaries. Yeah. Okay. What are the pillars of ethics?
Beneficence, autonomy, and justice, non-millions, and professional secrecy, sir.
Only
Okay.
four.
4 pillars, man.
Four.
Sir,
So Beneficence is one.
Yes, sir.
Autonomy is one. Then
Non-millions and justice,
what?
sir. No harm to the patient.
Okay. And then justice.
Yes, sir.
Just
It's
check on that.
non-maleficence, non-maleficence.
Non-maleficence.
Yes, sir.
Okay, non-maleficence. See, the first thing is, I think all of you, kind of touching the elephant and then saying that I'm touching the tail, I'm touching the leg. You should have answered it in a more regulated manner. See, the first thing is, what you have to understand is, this question has come from England. So the Church of England, the priests are allowed to marry. Okay, so they are not celibate, unlike the Catholics. So you have to first find out if there is a family. Okay, then you have to ask the priest, would he like for us to involve the family in the decision making, or he is going to make the decision? First of all, you have to find out if he is, fully compos mentis and is, is in a position to make the decision, because when you are very unwell and this patient is obstructed, whether he will be in the right frame of mind to make the decision. So you have to assess that, and second, you have to find out if he wants the family involved. If he wants the family involved, then you call them. Then you have to have a video interview. I think Nikita touched upon that. You have to have a video recorded interview in an interview room, explaining to them the condition of the patient, the diagnosis, the problems, and as you said, the what are the complications of the surgery, and what are the problems if you don't go through surgery. And despite and giving this informed consent, making sure the patient and the relatives understand all the complications of the surgery and also of not going through with the surgery. And then if they still decide that they don't want to go through with the surgery because of the whatever the priest has said. So I think the principles of conflict in this case is autonomy and maleficence, because if you respect the maleficence, then the patient, if you let him without getting any operation done, and you are harming the patient. On the other hand, the patient's autonomy is compromised. So those are the two principles that are in conflict in this case. And you have to document video documentation and documentation that you have explained in the presence of, maybe you have to have an independent observer as well, another consultant, for example, or a anesthetic consultant or an ICU consultant, somebody who is maybe involved in the case in the form of looking after them, but not directly involved in terms of surgery and things like that. So have them along with you, and then document that you have to document that whoever were present in the interview, and what have you explained to them, and this is the considered opinion of the patient and the relatives that they don't want surgery, and in accordance to the ethical principle of patient autonomy, the surgery has been deferred and the patient's wish has been respected, and you document that. So basically, this question is not intended to test your knowledge as to how you will manage the patient. It is intended to I understand and explain the ethical considerations of consent of the patient, and when the patient is reluctant to get operated. Now let us just quickly, because Vinod is taking the exam. Now you have a obstructing carcinoma of the sigmoid, which is, what is the situation that you are facing, man, Vinod?
Sorry,
Let,
sir.
let us move away from the ethical consideration, because this is a beautiful case. I just want to know from you. You have got a sigmoid carcinoma. Go back to the first slide, Samir. You got a sigmoid carcinoma with critical dilatation of the cecum. So what are you facing now?
Sir, it's an emergency, sir. It is something like a closed bowel syndrome, which is
Not closed bowel syndrome. What is that called?
Closed loop obstruction.
closed loop obstruction.
Who
Yes, sir.
said that? Who said that? Closed loop obstruction?
Sir, I said, sir. Nitya.
Nitya.
Yes.
Nitya, you have to restrain yourself. You are a registrar. I'm sure you know that.
Yes.
Give the postgraduates a chance, and then you can. I will ask you. Okay,
Yes,
so
sir.
this is closed loop obstruction. So what is the danger, Nikita? Nikita, hello. Is she there or not there?
She's on call today, sir. Probably.
Nikita is not. She left.
No,
See,
she's there in the chat. Maybe network issues.
Nikita. Okay, Praveen.
Sir, yes, sir.
See, as a general rule of for understanding for you guys, whenever you are in the class and you are called from casualty to go, you find out what it is. You know, many times if it is suturing and things, it can wait. But if it is anything urgent, please, either chat, put it in the chat, or inform that you had to go, because if I can't keep on asking questions to somebody who's already left the class. Okay, so please, not just me, the coordinator or the teacher who's taking the class should know that somebody's. I have no issues if you leave the class because you got to attend an emergency, but please inform us. Okay, Nikita, are you there, or Praveen?
Sir, yes, sir.
What is the
It
problem
leads
with
to,
the close?
yes, sir, strangulation and bowel ischemia, sir. And it may lead to
Okay, what
perforation and
else?
sepsis, sir.
What else? Strangulation is okay, I understand that, but more than that, what is the problem? They have put a very, I think a very good word.
Perforation.
Who's that again?
I
Sir,
told
me,
it's a
sir.
perforation.
Huh? Who's that?
Sir, Aina, sir.
Huh?
Aina, sir.
Inas, yeah. Perforation of cecum. See, it is critically dilated. What is the diameter of cecum you are worried about?
9
Beyond which?
centimeters.
9 centimeters, sir.
Correct. So you have a critical dilatation of cecum, so it is likely to perforate. Strangulation can also happen, but more than that, because cecum is a thinner part of the one, it will perforate before strangulation happens. Okay, so in this situation, Vinod, what will you do? How will you counsel the patient for surgery in this case? What are the options? Let us just enumerate the options. You
Yes,
have
sir.
every facility under the sun, every facility.
Yes, sir. But still, as it is an emergency, just maybe only one. If it is patient is stable CT abdomen, otherwise directly the patient to be.
CT abdomen, it has all been done. You know the diagnosis. So it is sigmoid cancer with cecal dilatation. So now how will you manage? What are the options? Just outline the options first for me.
Yes, sir. One is loop ileostomy, sir. Otherwise, just removal of the mass and then end end colostomy or
what is that called?
loop.
What is that called?
Hartmann's
procedure. Yes.
Yes, sir.
Loop ileostomy. Yes, if the patient is very moribund.
Yes, sir.
What other options are there? See, that is why I told you very clearly, every facility under the sun is there. See, this is the case. Anybody wants to add? Now I'll ask Nitya. Nitya, what are the options, ma'am?
Sir, since it's an emergency, we look at in terms of bailout procedures only, sir. Like
Okay.
stoma.
So yeah, what are the bailout procedures?
One is an ileostomy to relieve the obstruction. The next one is Hartmann's, sir, like resect the specimen and then do a stoma and come out, sir.
Okay.
And
it is what Vinod has already said. Anything to add? See, whenever the question passes to you, don't
yes,
repeat, don't parrot whatever has already been said. Add something of value.
I am not sure, sir.
Tanya.
Sir,
Tanya.
No, sir, even I can't think of anything. I was also thinking of ileostomy or Hartmann
Okay,
surgery.
so you have to see
can we
first
plan
of
in with
all.
colonoscopic, sir?
Huh?
Colonoscopic procedures, can we plan, sir, if it is not a full-blown obstruction?
What procedure? You are there, but
Stent
what
placement,
procedure?
sir. Stent placement, but clearance and
Correct,
stent placement.
correct, correct. See, that is one thing you have to think of. That is why I said all surgery and all facilities are available. See, this is a case where you have to consider colonic stent, especially because it's sigmoid. The stent is not going to migrate. So, if it is a complete obstruction and you are not able to pass the guide wire, fine. Then that's not an option. But under fluoroscopy control, you pass a guide wire past the obstruction and then deploy a stent over the obstructing lesion and then self-expanding metal stent. So what the advantages of this is, it will one relieve the obstruction, and what happens is the cecum, the pressure on the cecum will be relieved, obstruction will be relieved. Now what is the situation? The patient has come to you with obstruction. Maybe the patient has vomited for a few times, lost weight, and fluid electrolyte balance and all those things. So you have the next 4 or 5 days to improve the nutrition, correct the fluid electrolyte balance, and get the patient better, and then consider doing the definitive procedure, which would be to resect the lesion and do an anastomosis, which is, see, in this case, sigmoid colectomy, or what is fashionably called as a high anterior resection. So you consider doing that. The other thing that you have to say is, it depends on the condition of the patient. Is the patient very ill, or is the patient relatively stable though he is obstructed? So then what you do is, you can do few things. One is, you do a resection, and you can, if the patient's condition is stable and the anesthetists are happy, do an anastomosis, and because it's an emergency procedure, do a loop ileostomy. Okay, so that is you have to say that definitely. And other thing is, you can also do what is called as on table lavage. So you do, that is, these are these two, the last two options are if the patient is stable. So what you do is, you do, if the patient has not already had an appendicectomy, you use the appendix, do an appendicectomy and use the appendicular orifice to insert a large bore Foley's catheter, and then there is something, there is a kit available in England or Western countries for intraoperative bowel lavage. But here you can use the anesthetic, the scavenger tubings, and what you do is, you attach it to the bowel, that is probably in the descending colon, and basically irrigate with saline, and wash the bowel. So you do a intraoperative bowel preparation, bowel preparation kind of thing, clean up the bowel, and then resect and anastomose. In that case, you may not even need to do a stoma. So these are all the options. So you should not just confine yourself to ileostomy. The other option is to do a transverse loop colostomy also. So you have to, when you're mentioning a stoma, there are Western countries tend to prefer to do loop ileostomy. Indian surgeons prefer to do transverse colostomy. So you have to, in Indian, when you go to the exams in India, you have to mention transverse loop colostomy also, because that is liked by many surgeons in India. So just a diversion, either a loop ileostomy or a transverse colostomy, and Hartmann's procedure, where you resect the specimen, suture the rectal stump, and then give an end descending colostomy. You can also do stenting, and then temporize the patient and improve the patient condition, and then do a definitive procedure. Or if the patient condition is good enough, then you can do a resection anastomosis and then protect it with the loop ileostomy. There are other people also, and what I told you about the on-table lavage. After the on-table lavage, you have that cecostomy, that where the appendicular orifice was, and you bring that cecostomy out as a stoma, and then after when the patient is better, you can remove it. So that is definitely another option. So these are all the options that are available. So just with one question you can go as far as you want. Okay, I think there are
Sir?
no further questions. Yeah, Vinod.
Sir, in acute obstruction, can we do a colonoscopy, sir?
This is not colonoscopy. We are just doing see, this lesion is in the sigmoid. So
Okay, sir.
you go to the sigmoid and then see if the scope passes through. Most of the time it may not, because it is already an obstructing lesion. Then
Yes,
see
sir.
if the lumen is patent. Then you use fluoroscopy, pass a guide wire and see if the guide wire has gone to the other side, because you can see it has passed the thing and it's gone up to the descending colon. Then over the guide wire, you pass the stent will be in a collapsed state. So you pass the stent and then inject using a pneumatic dilator. You dilate the stent, and the stent is a self-expanding nitinol metallic stent. So because it is self-expanding, it will expand and it will dilate the colon, and it, because of its self-expanding nature, it will fit itself into the contours of the colon, and it will stay there. So that is what you do. So you are not going to do a colonoscopy, you are just going to do a sigmoidoscopy, because that is the way to do the stent. You can also ask the radiologist to do it, but it is better to you do it through the colonoscopy. Any questions?
And in such an emergency patient doing appendicectomy and doing a lavage.
No, that is why I told you it depends on the condition of the patient. But I have done it. I have
Okay,
done
sir.
this, though the patient, the patient has got an obstructed lesion. So the moment you do an appendicectomy, you can, decompress the bowel, right? So
Yes,
the
sir.
major
Yes, sir.
issue is, see, you can't do it if the patient is, hemodynamically unstable, or if the cecum is already dead. So
Okay, sir.
in that case, what will you do? If the cecum is already dead and you have a obstructed lesion in the sigmoid, what will you do then?
Yes, sir.
Hmm?
Then total.
Subtotal colectomy. You do a
Yes.
subtotal colectomy. If the patient's condition is bad, then bring out an ileostomy and leave to fight another day. If the patient's condition is good, then you do a ileorectal anastomosis.
Yes,
So
sir.
that is also an option. But I didn't bring that because I didn't imagine the cecum would be gangrenous.
Yes, sir. And what about the cecostomy, sir? I never heard this name. Sorry.
Yeah, what you do, see, appendicular orifice, you pass a 32 French or 34 French Polish tube,
Yes,
and
sir.
that you use to, the on-table lavage. After
Yes,
that,
sir.
what you do is, anyway, there will be a purse string around. So put, just like you do a jejunostomy, you bring,
Okay.
bring the tube out and secure the cecum onto the abdominal wall by putting two sutures on either side of the tube, and obviously the tube is secured on the outside also, and after 7-8 days you can gently pull out the tube. So and
Oh,
then the hole will close, because the bubble is patent, so it doesn't matter. It may leak a little few days and then it will close. So you can just put a bag on that, and a few days later it will stop. If there is no distal obstruction, there is no issue.
yes, sir.
So that used to be done very frequently. I think the usage of on-table lavage has come down enormously, because most gastroenterologists and surgeons are able to stent these lesions. So if they can stent it, then you don't need any of these things.
Yes, sir.
Okay, so
Yes.
I think we learned about both the ethical issues and the surgical management of an obstructing sigmoid cancer. Okay, now okay, who wants to take this question? Vinod, do you still want to have a go, or shall I give it to somebody else?
I'll try, sir.
Huh?
I'll try, sir.
Yeah. What are the options?
Sir, uh, the patient is hello, sir. Okay.
Ah,
Sir, the question. Can you come back to the question, please?
ah. Non-tender umbilical, irreducible non-tender umbilical hernia with a sac of around 8 centimeters in diameter. I think I don't know whether they're talking about this stack being 8 centimeter or the defect being 8 centimeter. Go to the next slide. What do you think?
I think this is the defect size, sir, 8 centimeter.
8 centimeters. Okay. So what will you do?
Sir, in this patient, basically he is a obese patient, sir. So we can do the surgery, or we can also advise for the patient about this obesity, sir. Planning for control of obesity if the patient is not tender, and if the patient is stable and there is no complications of this hernia.
There is, patient has come to you, it's already tender, it may be patient has got pain, so it's only a matter of time before it becomes tender. Fortunately,
Yes,
it is not tender yet.
Yes, sir. So then I'll advise hernia surgery, sir. But I'll also advise, because he's a obese patient, I advise about this um, bariatric surgery, sir.
Okay, that's not a bad thought.
Yeah.
Okay. Nikita, do you want to try, and Praveen after that, or Praveen first?
Sir, so usually we explain the patient that the cause for the hernia, obesity would be the contributing factor. We need to treat that also in order to prevent the recurrences. We should give a complete picture of what all complications also that can happen because of obesity. If possible, as sir told, we can counsel for the bariatric surgery. If they are willing, it's okay, sir. If they are not willing, we can go ahead, and with explained risk, we have to do the hernial surgery.
Okay.
As the sac is also big. Yes, sir.
So I think you answered the question partly, but none of you have brought the issue of LOD. What is LOD?
Loss of domain. That was I was about to tell, sir. As the hernial sac is big, there is a chance of loss of domain also. So, if possible, preoperatively, we need to, depending upon if the loss of domain is significant or not, we have to do the pneumoperitoneum, sir, to increase the capacity.
Okay.
If the patient is stable and we are planning an elective surgery, but if not.
So see that Nitya and Sanya, do you want to address this issue? These are very beautiful questions, actually. Come on, Sanya.
Yes, sir. Like Nikita said, first we need to have a complete evaluation of this patient.
See the CT you have. Do you want
Yes,
any
sir.
more information from the CT? You have to start there.
Sir, about the volume, sir, volume of intestine.
Calculating the loss of domain.
So what is that volume? What is the thing? There are two.
Tanaka index
Yes, sir.
and Sabag index.
Sabag. Yes.
So Tanaka is what is generally used, okay?
Yes,
But
sir.
the other one is also used. Tanaka is probably a bit more scientific. Okay. So what this CT, what is there? Is it sufficient? Do you think you want any more information? Normally, what is the slices that you get, and what would you want here? Anybody? Homework? Speak to.
Okay.
I think
sir, regarding the volume, sir, we need a 3-axis.
No, yes, that is there. So you have to calculate that, and the Tanaka's formula. Yes, that is one. The CT specifically designed for abdominal wall reconstructions. I think you have to know about what is the slices that you need to get. So that is the homework, because I don't want to give you all the answers. So that you need to find out and put up the answer in the thing. Okay. So basically you need a more focused CT to, as you said, to sort of get the exact loss of domain, and also look at other comorbidities if the patient has gallbladder stones or whatever, and all of those things, and then the characterization of the hernia, vascularity of the bowel loops that are there. See, that is important. See, the thing is, we don't know whether because the patient has got pain, is it the beginning of ischemia of the bowel? So you need to be certain that if the bowel is viable. So you need to look at the Doppler and maybe also look at the CT angiography maybe to ascertain whether the vascularity of the bowel is okay. You can also use these days, you can use the indocyanine to see if the bowel is viable. Okay, so that is what you have to consider. Then if the patient is stable and this bowel is viable, and what you can do is to give them Botox and then the pneumoperitoneum if the LOD is significant, and in that time give the patient time to counsel them and also give psychiatric counseling regarding need for bariatric surgery, because the BMI is 39, so it is morbid obesity. So the hernia surgery is bound to fail if the obesity problem is not addressed. So you have to talk to the patient and the relatives and get them counseled. And while you are doing all this pneumoperitoneum and Botox business, they have time to think, because there is no rush about doing these things, because that the bowel is viable, and you have got time to buy. So while you are preparing the abdomen with for pneumoperitoneum and Botox, counsel the patient and psychiatric counseling, dietary counseling, and see if the patient is willing and able to is motivated enough to have bariatric surgery. If he is or she is, then when you do the surgery, you do a sleeve gastrectomy, or if your preference is a mini gastrectomy, mini bypass, mini gastric bypass, or even a RYGB. And in addition, you have to reduce the hernia and then do, because depending on the LOD, you have to then decide whether, because it's 8 centimeter, whether you want to do a laparoscopic. I think the anterior component separation will be sufficient in this case, and component separation and a mesh repair, or if you are not confident, you can even do the open and anterior component separation and mesh repair. So this should be your thinking and answer. So that is I think all the 4 questions have been answered, right? Any doubts, any disagreement with what I said? Answer, come on.
No, sir.
Any doubts or any questions? See, whatever I said, I have given you my explanation. It may not be necessarily right, so you have to, if you want to differ, please do so, but you have to give me the reasons why you don't agree with me.
Sir, one question, sir. If with the 8 centimeters of defect, if it was there was no LOD, will you prefer open or sir laparoscopy?
Laparoscopy.
Laparoscopy. Oh.
I think laparoscopic repair. Either what you can do is do IPOM plus repair,
Okay.
where you put a 15 by 15 mesh, and then also do a hybrid or intro, if you are comfortable, do intracorporeal suturing of the defect. Or if you are if the depending on the thickness of the muscle and strength of the muscle and all those things, you can, otherwise you can do an anterior component separation.
Sir, for IPOM plus for a 8 centimeter defect, will it be not difficult to close the suture?
It will be difficult. That is why. But the thing is, because that is why it depends on whether the laxity and the strength of the abdomen. This one, if it is lax enough, then it will come together. If it is not lax, then you will have to think of other things. Definitely. 8 centimeters is 10 centimeters and above. Definitely, you need component separation. 8 centimeters is kind of near the edge. Okay. Right. Next question. Okay. Shall we ask Ainas, what is this procedure?
Sir, skin grafting, sir.
What skin graft, ma?
The split thickness, sir.
Split skin graft. Okay.
Yes, sir.
Yeah. So, what are the precautions or steps to be taken for this procedure?
You need to ensure that there is no underlying infection before you put in the graft, sir.
Okay.
And then also ensure that the vascularity is good enough, sir.
Okay.
So
Okay, good.
to take up
Then?
that, and so then
what?
so like these are the two I can think of, sir. Like
Okay. Samir,
Sir,
do you
healthy
want?
granulation tissue should be there, sir.
Huh?
Healthy granulation tissue should be there, sir, on the.
Correct. Correct. So you have to have healthy granulation tissue that has come up to the surface. You can't have, sort of troughs or pits where, collection can happen, and then that can cause the graft, for you to lose graft. Okay, so that is one. So the granulation should be to the surface and it should be healthy. Okay, that is third. Then what else?
Cultures should be taken, sir, to avoid any mm, growth, sir, particularly beta hemolytic streptococcus.
So what you are saying is you have to take a culture from the wound before you graft.
Yes, sir.
Is that what you say?
Yes, sir.
Anybody wants to contest that, or do they agree? Do you all agree?
Sir, I think
Any
the reports has to come and that
perceptions?
should be negative, sir,
Huh?
before
What?
going for.
Answer clearly.
Not just which is pre-operatively, sir, something like the reports of cultures has to come and that should be negative.
Correct. So, especially if it's a large wound, you have to ensure after you have done the debridement and the wound has been dressed regularly, you have before you decide on the graft, you have to take a culture from the surface and ensure that there is no growth. Because if there is underlying subclinical infection, that can eat the graft and cause destruction of the graft. So that is one. What else? Nikita and Praveen. Praveen, let us ask you to answer that. So all the four things, don't repeat it. Just add anything else if you have. So this is basically, going to the principles of wound healing. So what are the local factors? What are the systemic factors? Nikita?
Sir, if diabetic status should be under control, sir.
Correct. Yeah. Euglycemia or good diabetic control. And then what else?
so smoking cessation also
What?
like smoking, so like to ensure that they have good habits, like even that will improve the circulation, sir, basically.
You can ask them to stop smoking. Yeah,
Smoke.
agreed.
Patient nutrition status, sir.
Nutrition is good. I think finally the penny has dropped. So ensure that the patient is well nourished, and renal, if the patient has renal impairment, ensure that the renal factors are taken, because that is also one of the reasons why wounds won't heal. So renal factor, diabetes, and and then smoking, and any other other illnesses, like systemic lupus, or all these things that need to be under well marshaled before you take them up for surgery, arthritis and other things. So basically, make sure that all systemic illnesses are taken care of locally, no infection, good healthy granulation tissue, no culture, so negative culture, and good vascularity, and good patient hygiene. So these are the things you have to this one. Okay, fine. Now what are the methods available to maximize the coverage during procedure?
Just to mesh the graft, sir.
Meshing the graft. Okay.
You can fenestrate with the blade, and also.
Yeah, that is the same thing, fenestration, meshing. Yeah, same thing. So that will give you better coverage. And what is the advantage of meshing? or fenestrations?
Prevents edema, sir. Collection of serum.
Underlying hematoma, seroma we can avoid.
Yes, serum will escape, and so that it won't lift the graft up. Okay. So, and I don't think there is anything else I know apart from maybe using artificial skin, but I think that is also probably that's, I don't know whether that's what they were meaning. You can use artificial skin, you can use, what is called as a xenograft and all that, if you don't have the patient's own skin. Do you think you can use collagen in this situation? Anybody?
It's for the granulation tissue, which means deeper areas. I don't think for the skin it will help.
What?
Collagen is for the deeper tissue, sir. I don't think for the skin it will help.
Who's speaking?
Vinod, sir.
Who told that it is for deeper areas? Collagen dressing is used for skin, for burns, man. So
Yeah.
you can use it for this also, if at all. I think ideally, but it is expensive, and also it takes time. So basically, it can take anywhere up to 1.5 months for it to heal. So you use split skin graft, which hopefully heals by between 7 and 15 days. Then advantages and disadvantages of any other option,
Sir, for the area which is there, it is so large, sir. I don't think full thickness grafts is available for such large tissues.
No, it's not that long, man. It is only about what, 10 centimeters by 10 centimeters. So it's fairly easy to cover that. If you take a skin graft from the thigh, you can cover it. So
Split spin we can say, but even the full thickness can we do, sir?
why do you need to do full thickness in this situation?
No, that's what I'm asking. The only split skin is the option available, I feel.
So the option is split skin graft. If the skin is not available, you use xenografts or grafts from skin back.
Yes,
so
sir.
that is, I think, that is the option. Nitya, anything else you want to add?
Sir, even skin substitutes.
That's
That
what.
is a
Yeah, skin substitute. So you can either use that, xenografts, skin bank, or patient's own skin, or collagen. So these are the options. I think obviously the split skin graft is the best option, patient's own skin, and the take will be better and everything. Okay, I don't think there are many advantages and disadvantages of this. Move on to the next question. What is the diagnosis? Anybody?
Yes, sir.
Sebaceous.
Sebaceous.
Differential diagnosis. Sebaceous cyst is one.
Dermoid
Dermoid cyst,
system.
sir.
Dermoid.
Dermoid cyst. Correct. So how would you manage this?
Including the punctums.
Yes, excision including the punctum. But what are the precautions if it is dermoid cyst?
To check if
Intracranial
it has
extension is
any.
there. We have to
Bony
check, sir.
extension.
What?
Intracranial extensions.
I think intracranial extension, more than that, it is the involvement of the bone. So because dermoid cysts are subcutaneous, swellings in the anatomic midline swellings,
Suture line.
of anatomic, what is that?
Fusion, sir.
Fusion
Fusion
or
lines.
diastasis. Yeah. So you have to ensure that so you have to take, I think, a skull X-ray or even a CT to see if there is any bony destruction, bony erosion. I don't, Sani, have you heard of intracranial extension of dermoid?
Yes, sir. There are various types of dermoids. One of them it can be dumbbell shaped, when some of it could be extending into the cranium.
Okay, yeah. So I didn't know that. So in that case, you get a CT, ensure that there is no intracranial extension or bony destruction, and then proceed with the surgery. if there is bony destruction, you have to have options available to deal with that. So complete excision, and then what do you do for the bony destruction?
Bone graft, sir, or cement?
You can use bone graft. You can use from usually now bone grafts are being not used so much. You can from the anterior superior posterior superior iliac spine in that area, and you can use sort of cancellous bone. You can use bone substitutes, or you can use the what else? Cement, bone cement, as you said.
Yes, sir.
So you have to ensure that you cover the defect with that, and then if it is large enough, you may have to use a forehead flap or something to cover the skin defect if you are going to have a fairly wide excision. Okay, so that's about this question. Move to the next question. Okay, 78-year-old male with the swelling in the tip of the penis, is 3 months associated with pain. Go to the picture. Okay, so Vinod, you are the exam going PG. Answer this question.
Age and without any pain and 3 months of history of swelling, I probably think of penile carcinomas.
Okay, penile carcinoma is the thing. Different. Any differential diagnosis?
In that location, without any pain, I don't think any other.
He has pain. So anything else?
If the pain is there,
Anybody?
something. Hello, sir.
Pain. The patient has pain. At least that is what the previous slide said.
No pain, sir.
So go back.
Not associated.
Not is there a not there?
Yes, sir. Yes.
Okay, fine. Okay. I thought associated with pain. I didn't see the not. Okay. So, Sanya, any other differential diagnosis?
Sir, chronic melanoprostatitis causing ulcers.
Yeah, certainly you should consider, especially if the patient is diabetic, elderly. So they might have neglected that. So that is something you have to consider and rule it out. When you examine this patient, Vinod, what else would you examine?
I'll examine the inguinal nodes, sir.
Inguinal nodes. So which group of inguinal nodes will be involved in this case?
Both, sir, superficial and deep.
Yeah, but no, they are not only superficial and deep, they are also described as
Horizontal and vertical.
Yes.
horizontal and vertical. So which would you be more concerned about?
Horizontal, sir.
Horizontal. Okay. So you have to examine the lymph nodes carefully. Okay. Then how will you proceed? How will you get the diagnosis?
Um, I'll take a wedge biopsy, sir, from the mass.
Yeah. So what is wedge biopsy?
In which we'll take normal tissue along with the
Along with the lesion. Yes.
lesion. Yes, sir.
Why do you want to do that?
Because in the central area it will be only the necrotic material, and in the peripheries it is the area where the tissues will be actively.
Yes. One is that, and second is
Compare with the normal tissue, sir.
comparison normal tissue. Correct. And then what else?
Sir.
You will also be able to involve microscopic extension beyond the lesion, right?
Yes, sir. Yes, sir.
So if you have, the ulcer is stopping at a point, but if you take normal tissue, but there is microscopic involvement, then you will have to go far beyond that. Otherwise
Yes.
you would give a normal 1 centimeter, whatever. And I'm just giving you, example.
Yes,
So
sir. Yes,
just
sir.
you should take the periphery for the reasons that you have already explained. In addition, if there is microscopic extension beyond the extent of the tumor, okay, so that is one.
Yes, sir.
And also the grade of the tumor, you get a information about the grade of the tumor and everything, and obviously the histologic cell of origin. So what will be usually, what will be the tumor in this situation?
Squamous cell carcinoma.
Squamous cell carcinoma. What other things can be there?
Basal cell and melanoma, sir.
Correct. Melanoma, basal cell carcinoma. Yes. Okay. So, how will you proceed?
Sir, I'll also do a CT to know about the inguinal nodes status, sir.
Okay. And what else? Would you want to assess the penis itself? What will you do
Yes.
to assess the penis itself? Involvement of the
Corpora spongiosum, cavernosum, and urethra, sir.
So how will you do that?
MRI, sir.
You have to do an MR to identify the extension of the tumor, the relation of the tumor to the surrounding structures like the corpora and also the urethra.
Yes, sir.
Okay. Then inguinal node assessment, ultrasound usually sufficient. And if you are in doubt, you can even do an ultrasound guided aspiration by FNAC to assess the involvement of the lymph node. Other thing that you could do is potentially what? For you to assess the thing.
Sorry, sir, I didn't. Hello, sir.
Think of breast. What will you do when the nodal involvement is doubtful?
Sentinel lymph node biopsy.
Frozen section.
So sentinel node biopsy with frozen section.
Yes, sir.
That is also well described with CAP, carcinoma of the penis.
Yes, sir. Lymph node of Cabana.
Yeah. Okay, so you have to answer like this. You have to, all of these things, and then how will you deal with this? Will you do a complete amputation or partial amputation?
It depends, sir. If it is at least the minimum of 2 centimeters of stump should be remaining for a normal after this post surgery, sir. If it is not there, we have to go for a complete.
Okay. When you do complete amputation, what will you do with the urethra?
Urethra should be the urethral opening should be below the scrotum, sir.
So what is that called?
Perineal urethrostomy.
Correct. Perineal. So it's not. Everything is very simple, man. Perineal urethrostomy.
Yes, sir.
Okay. And if, for example, lymph nodes are involved, what will you do?
We have to both superficial and deep lymph nodes has to be excised as a envelope.
Groin dissection. You have to do it groin nodal dissection.
Yes, sir.
Okay. Do you have to do anything to the iliac nodes?
Always, first the inguinal lymph nodes will be involved, then followed by iliac lymph nodes, sir.
So only if the CT or ultrasound suggests that they are also there, then you may have. Otherwise, you just do a groin, inguinal node dissection.
Yes,
okay.
Sir.
What is the prognosis of this patient? 5 years
if it is,
survival.
I think, sir, if it is T1 tumors, the survival is around 80%, I think, sir. But if it is 2-2 or 3-3, it comes down to 50 or 60, sir.
Anybody wants to differ with that? Praveen? Praveen? Say something. Huh? No, but you have to say it. No, otherwise I don't know whether you are not listening to the question or you're absent from the class. You have to say something. Nitya, enlighten us. Has Vinod said everything correctly, or is there anything you would like to disagree or improve upon?
Sir, T2 tak it is 80%, sir. And I mean, even for the the most dangerous thing is the rupture of the blowout of femoral vessels. That alone, that can cause the death. But otherwise, the prognosis is not so bad, sir, even in the late stages, sir.
So that is why you have to do a proper node dissection and cover the groin, and so that you are given adequate protection to the vessels and everything.
Yes, sir.
Okay, next question. If there are no further. Okay. Let us, whom shall we ask this? Um, whom shall we ask? Vinod? Okay, let us go with Vinod first. Anyway, exam going. So when you do laparotomy, what will you do? So you have upper GI and lower GI endoscopies are normal. Okay. So
Yes, sir.
where are you going to look for? Where are you going to look for the lesion? Huh?
Sir, pancreas, sir.
Pancreas causing catastrophic bleeding. Is it common, man? Patient that doesn't have acute pancreatitis. Is it common to have such massive bleeding from pancreas?
Small bowel, sir.
Usually small bowel. So what are the most likely scenarios? Because you have already done a laparotomy, so I can't ask you other options. What if it, let us just for a minute ignore the fact that the patient is bleeding, of course, but patient is not hemodynamically unstable and is not crashed.
Yes, sir.
So what are the options available in that situation? Patient has bled. You have done an upper GI endoscopy. You have done a colonoscopy. What are the? Let us first just go through methodically. Upper GI endoscopy is fine, because you are going down the thing, so it's fine. You are assess the upper GI. Even if you want, you can even go up to D3, D4 also with the
Yes, sir.
what is called deep upper GI endoscopy. So you can
Yes, sir.
do that, and there is nothing there. Okay, there is no evidence of blood. Then you
Yes,
have
sir.
done colonoscopy. What are the disadvantages of colonoscopy in this situation? Patient is bleeding. Okay, so
Yes, sir.
what are the disadvantages?
Sir, if it is the patient is actively bleeding, we cannot identify the point of bleed if it is from
Why?
the small bowel. Yes, sir.
Not small bowel. No, you are doing a
Even in the large
colonoscopy.
bowel, even in the large bowel, sir, because the bleeding will obstruct the vision.
Yes, that is one. Second, more importantly, what is that? See, there are two things. You have to, anybody wants to answer that question before I explain it to you?
Yes.
Tanya?
No idea, sir.
So two things. One is you are going upstream. Okay, so blood is coming from above. So what happens is then this is unprepared bowel because you have you have not had, because the patient is unstable, patient is bleeding, so you can't do a proper bowel preparation. So when there is unprepared bowel, you blood is mixed with stools, so your scope is getting blocked constantly, you can't get good vision, and then you are going upstream. So what happens is you can't identify the point of bleed because everything is the hazy, and scope cannot see properly because there is blood. The vision is as you see, when for example, even when you have laparoscopy inside, if there is blood, your vision becomes suboptimal, right? Say yes or no.
Yes, sir.
Yes, sir.
So similarly, when you are in a much more confined space, that is the colon, you have a lot of blood, and the blood is impaired, interfering with your vision, and you are going upstream. So what blood is coming down, so you are actually being constantly hindered, even if you try to wash it. So, and then it's an unprepared bowel. If there is a lot of fecal matter, so that makes the matter even worse. And there is a potential for the scope to get blocked. And also, you can cause perforation because scope cannot, suck out the air, and you put in a lot of air, it can cause, obstruct perforation of the bowel. So you have to be careful when you do colonoscopy in unprepared bowel and in bleeding. But any experienced endoscopists know how to maneuver it, so you can at least get an idea where it is coming from, even if you can't pinpoint the exact site of bleed or the exact cause for the bleed. Okay, so you have done colonoscopy, you have done upper GI endoscopy, the patient is bleeding but not unstable. So, and again, I will stress the point, there is all facilities available to you. What will you do next, Vinod? Come on, man.
Intraoperative enteroscopy, sir, enteroscopy.
No, enteroscopy is a very difficult thing to do in that situation again. Yeah, you can think of that, but more, what is something that you can do? Enteroscopy
Angiography and
certainly.
embolization.
Correct. Who said that?
Vinod, sir.
Vinod. Yes, angio. So selective, you have to use the word selective angiography. So
Yes, sir.
you transfemoral, you go into the all the specific vessels and then inject dye and see where there is blush, and then you can, if there is a blush, so what is the rate of bleed for you to identify a bleeding vessel? More than what? 1
No
ml
idea,
per
sir.
1 ml per minute. Okay, so you should at least be bleeding more than 1 ml per minute. So you can identify the vessel, and this one. Other thing is you can also do enteroscopy, because see, I even though I stressed on all the facilities being available, enteroscopy in emergency situations is tough. It is okay to do it in chronic blood loss, not in acute blood loss, because again the same problem exists. um, again it is very difficult to identify the bleeding point, so because there is a lot of blood, so that is the issue. So enteroscopy also suffers, and you may not have enteroscopy available in, angiography may be available in emergency even at night, but enteroscopy will not be. So you don't say enteroscopy because it is an emergency. Okay, so that is one. Now we'll go back to the scenario which is there in the slide, that the patient is collapsed. So what is this they are doing? Anybody?
Intraoperative
Endoscopy,
enteroscopy.
sir.
Intraoperative colon
Enteroscopy.
is an endoscopy. So what you do is you do a cursory examination and find out where actually there is a lot of blood. So just proximal to that, make an enterotomy. Make an enterotomy, go proximal to that and ensure that there is no bleeding from the top, and then go downstream, and from the surface you may be able to sometimes see, most common when the patient is collapsed and all that, what are the two big causes for bleeding in this situation? Anybody?
Sir,
Huh?
gist.
Gist is one, and the other one is
Um,
arteriovenous malformation.
AV
Okay,
malformation.
AV malformation. So these are the two common causes for bleeding. So what you have to do is to see when you do a cursory examination, see if there is any obvious palpable lesion, and where is the blood concentrated, which loops of bowel. Sometimes when there is significant bleed, the entire small bowel will be full of blood, so it is difficult. But try make an effort to, because you have already done upper GI endoscopy and colonoscopy. Don't concentrate on the large bowel or small stomach, just concentrate on the small bowel, starting from ligament of Treats. Go through quickly, do a quick cursory examination of the bowel, walk the bowel, and see whether there is any obvious lesion that is obvious, palpable or visible, and or a visible blush in an area. You can see leash of vessels and things like that if it is an AV malformation. So that will give you a clue. And sometimes there may be a cherry red spot on the surface. So all of these will give you a clue that this may be the lesion. So then if you can't so do that, then you do an operative, it's an enteroscopy using either upper GI or the colonoscopy. Upper GI is only 1 meter. So colonoscopy is 2 meters. So you'll have a longer length. Then concertina the bowel over the scope, and keep progressing till you identify the lesion. Because this is a catastrophic bleeding, you will almost certainly find the source of bleed, because something that is obscure will not bleed so much. So you have to ensure, you can be sure that you will find the source of the bleed and deal with it. So depending on what it is, you can do a resection of the segment. And what if it is an AV malformation? Remember, the AV malformation is much far beyond what meets the eye. Okay, that means, let us say there is a blush of vessels involving 2 or 3 centimeters of the bowel, but in the what shall we say, submucosa and things, the lesion extends far beyond. So you will have to resect a bit more than that. So otherwise, you can have further bleeding post-operative. So you have to be careful about that. So AV malformations, a bit more normal, whatever you give her another 2 or 3 centimeters or 5 centimeters and resect a bigger segment, so that you ensure that you have resected all the entire AV malformation, so that it won't further bleed in the post-operative phase. Resect the segment, resect the lesion, and do a end-to-end anastomosis. So that is the so I've explained to you what are the methods of identifying the obscure GI bleed. Okay.
Yes,
So
sir.
this is in the acute situation. In chronic situation, you have lot of other options. Anybody wants to enumerate what are the options? Who's silent
The
today?
capsule
Capsule
endoscopy.
endoscopy.
Capsule endoscopy. Yes.
Double balloon enteroscopy.
Double balloon enteroscopy.
You can get an
And
angiogram also, no, sir? Like CT
angiogram,
angiogram.
before angiogram, you can also do what is called the tagged red cell
Yes,
technicians
Yes.
sir.
per technique
Tag
scan.
buds.
So that can also give you the point of bleed, and then after that you can pinpoint, if it tells you where it is coming from, then you can do an angiogram and identify the source and then deal with it. So these are the options. It's already 10 o'clock. Any questions on this particular topic?
No, sir.
Shall we stop here?
Yes, sir.
Yes, sir.
Any questions or any comments on the discussions? Was it appropriate? Was it helpful to you in dealing with clinical situations? Because
Definitely helpful, sir.
the thing is, in ward rounds, don't go too much into theory. You are only going to go practical aspects of a particular problem. You don't go into very basics of the theory and all that. Because that is what they expect of you. In the ward, if you face in a situation, what will you do? So that is, they are testing one your fact that you have actually worked on the wards or not. And second, if you have worked on the wards, are you able to think on your feet in an emergency situation and then come up with the right options for management. Okay, so that is the purpose. It shows your day to day, perioperative, preoperative. Sometimes you have preoperative because that consent and all those things were preoperative. So preoperative, intraoperative, and perioperative understanding of the problem and management. So that is what is the purpose of ward rounds. So I think we have covered quite a few cases today. So if you don't have any questions, we'll close the class. Good night to all of you. Good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you,
Good
sir.
night.
Thank you.